Well, perhaps we can include a brief introduction as well as we go. My name is Joe Frank. Thanks everybody for coming today and for having us present in this conference. I'm faculty in the Division of General Internal Medicine and a general internist by training. And my clinical work is now over at the VA in our multidisciplinary, I'll say our interdisciplinary chronic pain program called the Chronic Pain and Wellness Center. So that's a perspective that I'll be presenting from. I'll let my colleague Dr. Ashar say hello as well.
Yoni Ashar, I'm new faculty here, started in July. Before that, I'm a PhD in Boulder, CU Boulder, and my background in clinical psychology and neuroscience, cognitive neuroscience, human.
Great. And so we're going to be talking today on pain reprocessing therapy, initial findings and future directions. We hope to have plenty of time for focus on those future directions and questions from the audience. A few disclosures here to share, and I'm just going to really provide a fast and broad overview to where we are with chronic pain in the U.S. Shown here is an image of somebody going through their life at a cocktail party and in the mirror, hiding the actual experience and what it feels like to go through the day with, in this individual's case, severe chronic low back pain. And what we know about chronic pain is that it's highly prevalent. So 50 million Americans live with what we call high impact chronic pain, so daily affecting activities. A now 10-year-old estimate of the cost of chronic pain is close to $600 billion. Again, 10 years ago, that's in medical costs, that's in opportunity costs for people in the workforce. We have a range of treatment options, but often a lack of effective treatments for individual patients. And so when we try and put together our evidence-based treatments, they're still typically moderately effective for most people, and we're working with patients to put together a treatment plan, which generally for people living with long-standing chronic pain can be somewhat agnostic to the location of pain, the mechanism of pain, which leads us into our talk today, thinking about a neuroscience-based approach to diagnosing chronic pain. For most practicing clinicians, these are not terminologies that we routinely use. ICD-11, somewhere out in the future for all of us practicing in the US, but we'll introduce a new construct of primary chronic pain. So primary chronic pain being compared to secondary chronic pain. We're going to talk a lot more about what we mean by chronic primary pain. And we're also going to introduce this term of nociplastic pain. So you see three terms here: nociplastic, nociceptive, and neuropathic. The other term we'll use is centralized chronic pain. And on this spectrum left to right, we see peripheral injury contributions on the far left. And for many people living with chronic pain, it's going to be a combination of both, with peripheral injury contributions being primary at the time of an injury, at the time of onset of a health condition. But as the injury resolves, symptoms persist. You see this black dot move left to right, in which central nervous system contributions become predominant, which should shift our treatment approach. And I'll hand it from here to Dr. Ashar.
Thanks, Joe. Yeah. So picking up from that introduction from the great previous talk, where we've heard a lot about peripheral pathology, like in joints, can be a problem, but there's often not a one-to-one correspondence with symptoms, with pain, right? So what's driving the pain? And one thing we've learned is that there's a range of changes across the central nervous system in chronic pain, from the periphery to the spinal cord to the brain, and in many cases, these changes can drive the persistence of symptoms after injuries have resolved, or in the absence of any clear identifiable pathology in the body, in the peripheral tissue. This has had us all reconsider what pain is. In the old traditional view, pain was a one-to-one readout of tissue damage. We now know it's far more complex, and I often think about pain as a learning signal guiding behavior. So as an organism or a person is navigating the world, we're looking for rewards and trying to avoid threats. And to do that effectively, the pain system has to be predictive, has to be forecasting threats to avoid them, to survive. But prediction is a very difficult problem, and sometimes these predictions can be wrong. Recent predictive or Bayesian models have taken their framework, where the nervous system is always trying to anticipate and build an internal model of sensory input, internal model of the world, and then sensory input is compared against the internal model, and that's integrated to create the pain experience. What's shown in yellow is a prediction of pain. Blue would be the afferent input from the body, and green is the actual experience of pain, which is an integration of both what's anticipated and what's the input. And yeah, this fits into a larger kind of body of literature of a network of brain regions that are trying to keep track of what's happening both in the world and internally, and update that. And it's often a reverse inference problem. Given the sensory input, what's the state of the body? Okay, I have sensation coming from my back. Is there an injury in the back? Yes or no? That's an inferential problem. And the brain fundamentally doesn't know if an injury is present. This has informed this fear avoidance model of pain. At the heart of the model is this decision about whether the pain is high or low threat. When the pain is categorized as high threat, the brain will prioritize its processing and drive a cycle of avoidance behavior and catastrophizing and negative affect. So this is going to be a very brief overview, but so this would lead us to think, particularly this fear avoidance model, that well, psychological treatments can work quite well for chronic pain, right? Help people, appraise pain as low threat and break out of the cycle. And if the body really is basically healthy, then the pain should be absent. But what do we see with leading psychological treatment? So cognitive behavioral therapy is the most studied. Over 59 trials, 3,000 patients. The effects are very small in pain intensity. Why is this not working? I'm gonna pull back the hood on one of these treatments. Here's a quote: "Pain is usually an important message from the body, alerting the brain that something is wrong and needs attention. This book, or substitute this treatment, CBT Act, right, will target the suffering caused by your pain, not the pain itself." So the premise here is often that the pain reflects an injury in the body, although we know that's not always the case. We know symptoms and injuries not one-to-one, and that the treatments are often not even targeting the pain, just try to help someone live more gracefully with the pain. But leveraging what we know about how pain and affect are constructed by the brain, could we do better? And this is sorry for the formatting, switch from Mac to Windows, and yeah. This has led to the kind of development of an approach we're calling pain reprocessing therapy. I'm going to show you results from our first clinical trial. Patients completed the fMRI brain scan and a blood draw to look at inflammatory markers and patient-reported outcomes. They were randomized to one of three conditions: the usual care, a placebo injection, or this pain reprocessing therapy. I'll tell you more about that on the next slide. And a return post-treatment for an identical assessment session. In a nutshell, PRT aiming to assess, the centralized versus the peripheral contributions to pain. It's very much an open challenge. You'll see in our future directions. How can we do that reliably? When pain is found to be centralized, providing education that the pain is is due to plasticity in the central nervous system. This is reversible. You're able to learn this. You're able to unlearn this. And then a series of exposure and reappraisal techniques, trying to reappraise the sensations as safe, using this kind of inhibitory learning framework. These movements or these postures in your body have been associated with pain. Can we create a new association with safety? Mindfulness element, certainly exposure to the PRT. If it's bending, if it's twisting, patients are doing this. And I'll show you the clinical outcomes here. Pain intensity is the primary outcome. We follow patients for 1 year after treatment, as you can see on the x-axis. And in the usual care condition, we observed as commonly found a small reduction in pain from 4 to 3, and then it holds for about a year. Moderately sized but significant placebo effect at post-treatment that is not remaining for the full follow-up period. And in the PRT group, a large reduction in pain that was largely maintained for 1 year post-treatment. So we were quite encouraged by these results. I'll say I was very surprised and in a positive way by seeing these results when we looked at the data as well. To look at this data one more way, hopefully the formatting will cooperate. Each dot here is a particular patient. Usual care, some people got worse, some people got better. Placebo looks a bit better. In the PRT group, see, nobody got worse. One person stayed the same. Everyone got better. But what really caught our eye was this cluster of people with 100% reduction. And for those who aren't familiar with the chronic pain, psychological treatment literature, this is not commonly observed. A cluster of people saying, "I'm not in pain anymore." Just to operationalize this, we defined a category as pain-free or nearly pain-free. So people reporting 0 or 1 out of 10 pain, and 2/3 in the PRT group were reported being pain-free or nearly so. At post-treatment, about 50% at 1 year follow-up. And I want to put a human face on this. These are short videos from two people in our study who consented to have their videos shared. Hope the audio works. We'll find out.
I can honestly say I have zero back pain right now. It's drastically different. I think I was 7, 8, 9, when I came in.
18 years. And it never stopped hurting for 18 years. I don't have any, I'm pain free. It's amazing. I can't even believe I'm saying it, but it's true.
So this is, what are the main questions that emerge from us? Like, how does this treatment work? How does people go from 18 years of pain to be pain free? What's going on here? And that's motivating a lot of our future work. I forgot to include the slide here, but we have fMRI brain imaging of patients pre and post, and a back pain evocation procedure that during fMRI we first a painful back extension. And what we found is reduced pain responses in the anterior insula, the anterior cingulate, anterior mid-cingulate, and anterior prefrontal cortex. And those are brain regions that generally involved in construction of, in the pain processing hierarchy, they're relatively near the top of the hierarchy, involved in predictions about pain, making meaning of pain, and more broadly involved in construction of negative affect. And so consistent with this theory that we're changing, the brain's predictions of sensory, of pain and input, but there's a lot more to unpack in terms of what's happening at the level of the brain. So what we decided to highlight in this talk is, future directions, kind of given these results, what do we have planned in the coming, the near future. So there is, we're launching a clinical trial, November, hopefully, comparing PRT to CBT. It's an overview slide. We'll get more into each of them in a moment. Natural language-based approach to symptomatic regions, that'll make more sense. Tools for diagnosing centralized pain. So a particular patient, how do you know? Is this generation? Is this rheumatoid arthritis? Is this the brain amplification of symptoms? And then a feasibility study among veterans with complex chronic pain and opioid dependence. So this is our upcoming trial. We're comparing PRT to cognitive behavioral therapy. It's aiming to address, there's actually not going to be fMRI in this trial, unfortunately. 3 critical limitations from the prior work is, one, there was not a good control group. This placebo control is not ideal in many respects. So we're having a well-matched, kind of gold standard CBT control. The hypothesis is superiority, that this is going to be, PRT is going to be superior to CBT. The patients in the first trial were relatively white and well-educated and employed, and we're aiming to recruit a more diverse sample in this trial, and different clinicians. That the clinicians in the first trial were those who had developed PRT. And so can we have other clinicians also get people out of pain in that work? So if you have any friends or patients with chronic back pain, please think of us, send them to our trial. We'll be recruiting hopefully next month. Another approach that I am been excited about is understanding how people think about the causes of their symptoms. And in that trial I showed you, we asked people to tell me in your own words the top 3 causes of your pain. So a very typical response would be old age, football injury from 30 years ago, and bad posture. And when you categorize these responses, you see very, very few people are saying anything about the brain or anything about the mind. Although scientifically we know, and if a brain's been in pain for 20 years, there's going to be some learning, some sensitization that's happening. So we categorize these, blind coders categorize these responses. Hopefully you can see it from there. But basically at pre-treatment, as I was just saying, there's very few responses that have anything to do with, psychology or brain are in the top right corner, a little bit of stress. Post-treatment, many people are thinking that the causes of the pain are something psychological or brain-related. That's a little small, but this is what I'm showing here is the application of a text scaling algorithm to this data. This is a unsupervised kind of machine learning data-driven approach to seeing how the semantic dimensions underlying how people think about the causes of their pain and you can't quite read it. But this dimension goes from work, car, lifting, core, poor, to stress, neural pathways, anxiety, fear. So just confirming that this is a kind of critical semantic dimension underlying how people think about their pain. And I'm excited about applying this approach to a broad range of symptoms. We're working on automated ways to apply this kind of scaling algorithm to symptoms more broadly here. Because this is a key mechanism of how we think PRT works, shifting people's attributions about the causes of sensations. This diagnostic question. So one is we need better clinical diagnostic procedures and screening questionnaires. Another approach I'm excited about is diagnostic brain biomarkers. I'm highlighting here work from a colleague. This is a brain biomarker of fibromyalgia that's found in this study, close to like 90% accuracy, diagnosing fibromyalgia versus healthy control from a multisensory battery. And Dr. Moreland and I just submitted a pilot grant for looking at something similar with knee pain and knee osteoarthritis pain. Can you identify brain biomarkers indicating brain contributions to pain as well? Joe, you can do it.
And then the next item that we want to highlight is thinking about, in addition to the randomized trial that Dr. Ashar presented, how can we begin to learn about integrating pain reprocessing therapy within the context of team-based pain care? So at the VA, I think we're in an unusual and fortunate situation that we have a interdisciplinary team. You see behavioral health provider, medical provider, clinical pharmacist, nurse care manager. This is really the team that we engage with veterans with complex chronic pain, often long-standing chronic pain. And sometimes typically we're already providing these bottom two, opioid tapering and or a switch to buprenorphine. We can talk more about that if that's interesting, and focus on active self-management and care coordination. But in our typical model, the behavioral component is going to be CBT. And so we want to think about how we can target a group of patients prescribed opioids, again, often at high doses for a long period, using PRT to focus both in all the ways that Dr. Ashar has described on as an additional modality, an additional treatment for pain. We also know that medication changes, opioid medication changes, can involve substantial symptoms as well. So learning in this pilot feasibility study how we can engage these same procedures within PRT to help patients think about and sort of develop meaning when it comes to other symptoms that are going to come up in the context of chronic pain or opioid tapering. Those are really, I think, a summary of our key next steps. We want to say thank you to a range of funders that have made different aspects of this work possible. Thanks to this group for having us here this morning, and hopefully we have some time left for questions.
That was wonderful. We have time for questions. Did your technique work for complex regional pain syndrome?
Excellent question. I'll just say that this is one of the areas that we're interested in moving this forward at VA. I think this appears to be a relatively common condition among the veterans that we see at VA. I think we presented a trial looking at back pain. I'll say that the mechanisms that we're describing in centralized pain and neuroplasticity certainly seems compelling that it would. But to my knowledge, PRT is early. We don't have data with that specific condition. I think another direction here would be talked about back pain, talked about knee pain, expanding this to a broader group of pain conditions, pain locations, think about widespread pain, fibromyalgia. Certainly the rationale holds up well for those conditions. Yoni, what would you add?
Nothing. That's good. Yeah. I think some clinical anecdotes of efficacy, but no data. Yeah.
So I was wondering, with your first group that you showed the really impressive results with, can you tell me a little bit more about how much of that was, if you were able to say, was central versus, again, something peripheral? Was it a mixed group? Was it a fairly homogeneous group? And then the other thing, and maybe I missed it, is probably is not easy to do for somebody like me who doesn't know this, but can you give me a thumbnail of what you do in PRT?
Yes, absolutely. Okay, I'll start with the order you asked them. So I think the diagnostic procedures are still very much a work in progress. Using the procedure that this clinical team used is looking for early indicators like has there been a spatial spread of pain? has pain, the pain start, maybe lower back and now is spread to the upper back? Is there a history of other chronic pain symptoms like headache and knee pain and tummy pain and back pain? Is there a lot of context sensitivity to pain? So pain hurts when you're at the office, but not when, back hurts at the office, but not on the weekends. So those are all clues that we've been using to try to, as positive indicators of a presence of centralized contributions. In this trial, the main thing we did was exclude people with leg pain worse than back pain, because that's a potential indicator of a radiculopathy. And of the 50, I think of the 48 that were assessed, 44 were found to be centralized pain. And if you look at the literature, common estimates are like 85 or 90% of back pain is what they call non-specific or centralized pain. So it's consistent with that. But then, how do you really know? It's a really good question. Like how do you really know what's the cause of pain? So it's difficult. It's difficult to know, and I think there's no gold standard procedure, and different clinicians would have very different conclusions. Slide somewhere. But all of the patients in that trial had at least one anatomical finding, like disc degeneration or scoliosis, and they all had that. But our clinical team judged those to be incidental and related to pain. We know they often can be. Other people might say, well, that might be contributing, and so it's not. Okay, what is PRT? The heart of it is reducing fear of pain by thinking about the pain as a false alarm. So it's like the fire alarm in your house is sensitized. Now it's going off every time putting some toast in the toaster, but there's actually no fire in the house. There's nothing dangerous happening. And the main techniques are this somatic interoceptive reappraisal technique, where you help people pay attention to the pain, like turn attention inward, pay attention to the pain, and remind themselves that they're safe, there's nothing dangerous going on. And then starting to do the things that they've been afraid to do. When patient hurt their back playing tennis, they're playing tennis again. So that's hopefully gives you a little thumbnail of it. Yeah.
I was more curious about that cluster of patients where you said they have no pain.
Yeah.
Right? And the question I had, these patients or the subjects, they were going to the same clinic, they have some different kind of medicine, or they have some kind of a special exercise or one area, that's what I think.
Yeah, are there any like concurrent treatments that they were getting?
Yeah.
I don't have a great measure of that. To the best of my, we might expect that there was like a similar distribution of concurrent treatments across the three groups because it was random assignment, but it's possible there's concurrent treatments going on that we don't know about. But yeah.
There's a question online. I did not see physical therapy mentioned in the multi-D clinic approach. Is there a place for the PT discipline in the implementation of PRT?
Excellent question. I think that's an oversight on my part. So it should be there, and certainly as we're talking about assisting patients getting back to important activities that have been limited, I think physical therapy has a really important role to play. I think physical therapy has a stronger track record certainly than sort of my clinical training in pain education, addressing some of these issues related to pain and fear. So I think lots to learn from physical therapy and certainly belong on this team.
Pretty much. Add to that this is speaking as a total outsider of the physical therapy, but from speaking with physical therapists, there seems to be two camps. A camp that's very focused on like your back hurts because your abs are weak, and a camp that's more focused on, your brain has learned the pain, we can get you active again, teach you how to do these movements and learn that you're safe. And PT would definitely be much more synergistic with PRT if it's coming from a brain-centered approach than like the weak abs approach. And
I
getting mixed messages.
I think those messages are true across all the disciplines involved. I think as I'm having similar conversations with patients, they're often coming having been told the exact opposite at some point in the past. Your back is severely injured. This is the worst MRI I've ever seen. You'll never do blank again. So this is a big change, both for a team of clinicians who's gearing up to provide this treatment, as well as trying to communicate it effectively with patients who have heard the exact opposite.
I think this is very exciting. Could it be potentially applicable to other things that are under some, chronic conditions that are under somatic control? For example, in my clinic, we deal a lot with chronic cough syndromes and people with dysfunctional perception breathing disorders. That the moment, the brain really plays a trick, that those signals are coming in and the way it's been interpreted and responded to. Very similar to pain.
Exactly. Yeah, hypervigilance, fear, right? A cycle of reinforcement learning where you cough and you relieve the sensation, and so that feels good. So your brain learns that behavior. Yeah, absolutely. I think it'd be great.
Could I ask you, I think you got at it a little bit with your natural language processing study, but the acceptability of RPT, CBT among patients with chronic pain on opioids. I mean, have you looked at it, or is that a consideration? I just have the idea that if you have to tell a patient in front of you with chronic pain that it's all in your head, that's a difficult, that's a really tough conversation. So curious if the acceptability of this in your clinic so far.
Important that we measure it better going forward. I would say that many people have heard that phrase, that sort of phrase looms in these conversations as sort of a really negative interaction at some point in the past. They told me it was on my head. I think being able to address it head on, to say, you may have heard, but that's not what we're saying. This pain is real. Then I think the other thing we often hear from patients prescribed opioids for many, many years is, would love to stop this. What do you got?
Yeah, what do you got?
So I do think those will be sort of, in balance a little bit. People are interested in feeling better, haven't found an alternative that works better than where they're at. And so hopefully that's a place we can focus.
You have time for one quick question.
Sure, the question, how does PRT differ from Adrian Lau's pain neuroscience education approach? There's a lot in common. In a nutshell, what I think is different is that we provide personalized evidence for people that their pain is centralized, which I think the PNE approach is more generic, and then includes these somatic interoceptive techniques for reappraising the pain, which I don't think is part of PNE. But the conceptual framework is quite similar.
And I'll just add one other similarity is that many patients living with chronic pain are going to have a lot of trouble finding either of these. And so I think it can be, if many people presenting to primary care to say, can you refer me for pain neuroscience education? They're probably going to be what's that? So, I think more of each of these is progress. But
Yes, I agree.
Thank you.
I agree.
Thank you.